full course of internal medicine? Or you had before?
No, doctor, is the first.
Nice, good. Again, glad to meet you. And could you please comment whether you have started your practical classes already?
Yes, doctor.
Mhm. What topics have you already discussed in the practical classes?
Sir, I forget.
Mhm, mhm. Maybe bronchitis or something like that? Pneumonia, no?
Yes, it's bronchial asthma.
Oh, great. So, and our today's topic, for instance, concerns bronchial asthma and chronic obstructive pulmonary disease, two of these topics. Hope this would be useful for you and your classes, in your studies, and further practice. I just wonder whether other students are coming or we should start without waiting them. Do you have any ideas about this?
We should wait. I will send in group.
Could you repeat, please?
I will write to students for join.
Okay, thank you. Just a few seconds.
Okay, doctor.
I'm starting the presentation. For instance, did you check the description in my invitation to your lecture? There are, let me show on the screen, just one moment. I'll share the screen. And, oh, pardon, it's not proper. Other screen. I have three of them simultaneously. Okay. So do you see the screen at the moment?
Yes, yes, I see.
Good. It's bronchial asthma, right? Good. And let me show the invitation in your, for example, in this case, Google Calendar or in other media you use. There is a registration and feedback form here. Do you see it?
Yes, we see.
Please register, and I will check if everything is okay in the Google Sheet. Okay. Just follow the link and
We should write now registration.
uh, anytime you want, but don't forget to do it because we'll mark the attendance for this lecture based on the data filled in this form. Okay.
Okay.
Yeah. So you may do it now or in an hour. Better if you finish it before the end of lecture, maybe on the break or anything like that. Okay.
Okay, sir, I understood.
Good. Good. So I start the presentation, and those who will be later hope will join us. Anyway, if even someone will not come, I started the recording of our discussion of our lecture, and they will have an opportunity uh, to see look through the lecture and get any information we have discussed with you. My name is Oleksiy Kalmykov. I'm professor of Kharkiv National Medical University, the Department of Internal Diseases, Internal and Occupational Diseases. This presentation was prepared by my colleague from Lviv National Medical University, Dr. Mazur. I kindly appreciate this, and my duty now is to represent the basics of bronchial asthma for you students of stomatological dental faculty of Kharkiv National Medical University. So we'll go through definition, etiology, pathogenesis, diagnosis, classification, and principles of treatment of bronchial asthma. First, by definition, before I continue, if you realize you have any questions, especially immediately interactively, let me know about this. You may write anything in the chat. I'll check periodically or if it is urgent, just tell it aloud and we'll discuss. I'll answer. So let's continue. By definition, bronchial asthma is a disease characterized by chronic inflammatory changes in airways. Most often, bronchial asthma is associated with allergic origin. We name this atopy, right? Allergic component. And it is characterized by obstruction, disturbance of patency of bronchial tree, and the characteristic aspect of this obstruction is reversibility under the influence of broncholytics or spontaneously. And other aspects of bronchial asthma nature is increased responsiveness and narrowing of bronchial wall. So again, if we combine all these together, bronchial asthma is inflammation associated with atopy or allergy, with obstruction. I must say even it's reversible obstruction. Inflammation, atopy, reversible obstruction. There are 4 basic and 1 additional mechanisms of this bronchial obstruction. It's hyperproduction of mucus. It's first. Increase of viscosity of this mucus. It's second. Then narrowing or edematous condition of bronchial wall. And finally, bronchoconstriction. It's constriction of bronchial musculature with narrowing of the bronchi. And I promised you the 5th component of this mechanisms of bronchial obstruction. It's remodeling or deformation of bronchi as a result of prolonged inflammatory and fibrosis processes. Good. The prevalence of bronchial asthma varies by age, by territory, by even it differs in urban and rural regions and so on. So there are different epidemiological aspects of this disease, depending on how often and how much of allergens are present in the environment, depending on the congenital factors like genetics and so on, depending on the level of healthcare service, its quality, and so on. And it also it correlates with the economic condition of appropriate region, of appropriate country, and so on. A few words about mechanisms of development of bronchial obstruction, bronchoconstriction, bronchial asthma, and so on. A significant role is played by so-called cellular or inflammatory or allergic mediators. It's a group of substances released by mast cells, labyrinths, eosinophiles, lymphocytes, and so on, in the response to some internal or external agents influence. It could be internally due to some peculiarities mm, uh, of genetics, right? It could be congenital and so on, or more often as a result of some exogenic, external influence of allergens. They could be chemical substances, or they could be some components of biological objects like parasites, or it could be pollen dust, or just pollen itself, and so on. The following uh, representatives of these mediators uh, are placed on this slide, like a group of leukotrienes, histamine, a group of prostaglandins, platelet activating factor enzymes, cytokines. It's cytokines is generally is general name for these cell mediator. Cytos means cell, kines or kinos in Greek means movement, right? So there are uh, those substances which either attract different cells to the place of production of these substances or activate them uh, or vice versa. They could be like positive or negative cytotaxis or inhibition of some functions. It depends. And even in combinations, different cytokines may result in uh, wide spectrum of biological effects. Formally, we may distinguish two types of phenotype of immune response by T helpers of first type and T helpers of second type. We have also third type, but in this case, we distinguish, it's mostly important for us to distinguish these two. The factors which incline the organism to conduct the response by Th1, so T helper of first type phenotype, are presence of older siblings, early exposure to daycare, tuberculosis, measles, hepatitis A infection, and other infections, rural environment with plenty of pollen agents and other aspects. And in this condition, when there is Th1, T helper of first type response, type of response, we mostly have protective effects, adaptive and protective effects. While in case of T helpers of second type phenotype realization, we mostly have such agents as widespread use of antibiotics, Western lifestyle, urban environment, diet, sensitization to house dust, mice, and cockroaches. And really, these results rather often not only to more specifically bronchial asthma development, but to development of other allergic conditions, allergic diseases, and bronchial asthma among them. And very formally, this balance may be represented as one of mechanisms of development of bronchial asthma, which should be taken into account by medics in general, medical staff, and medical doctors more specifically. Again, The main components of bronchial asthma mechanisms of development include bronchial obstruction. The more important aspect of this obstruction is reversibility, at least partial, as it is opposite to our next disease for today's lecture, chronic obstructive pulmonary disease, when bronchial obstruction is much less or at all irreversible. Second component is hyperreactivity of bronchi, bronchioles to uh, factors, mostly exogenic factors. Development of inflammation in locus morbi, in this case in bronchi. And main uh, components of these are represented on this slide. It's degranulation of mast cells, it's bronchospasm, it's edematous condition of mucous membrane, it's also degranulation of eosinophiles and involvement of lymphocytes, more specifically of T helpers of second type. Th2, if you remember, we have discussed this just slightly before. On this slide, um, peculiarities of this process are represented with illustration of migration of the cells involved in this atopic response, allergic response, and reaction of mucous membrane and muscular components of bronchi, and starting from bone marrow location and up to location in the place of inflammation. Here's the outlook of the bronchus, the bronchiole probably, with signs of inflammation, edema, hyperproduction of mucus, and other components we have discussed with you. You may see how many uh, cellular components are present in the mucous membrane, especially. Here is the bigger magnification and the comparison of this condition, uh, of the condition of mucous membrane in norm, and in bronchial asthma. From clinical, do we have any questions regarding bronchial asthma mechanisms, maybe causes at the moment?
No, sure. All is okay.
Okay, good. Good. Let's continue. So about clinical level of or clinical aspects of the bronchial asthma. The diagnostic criteria for bronchial asthma includes presence of dry, irritative, repetitious cough, dyspnea, breathlessness, right? This dyspnea has expiratory tinge or character with limitation of on expiration phase, the speed of expiration phase. The sound of wheezing on expiration phase again, so such a dry rheals, even distant rheals. These symptoms are main, but not only, they could be some accompanying foci of allergy, for example, from side of other locations of mucous membrane, on eyes, on oral cavity, in gastrointestinal tract, and so on the skin, like atopic dermatitis, for example, eczema, and so on. And but these three, cough, dyspnea, and wheezing, are main and enough for stomatologists, for dentists to suppose probable presence of bronchial obstruction and more specifically of bronchial asthma. These symptoms are recurrent, they are not stable, they are not constant. They appear and decrease. They might grow up and again decrease in their intensity, depending on the contact with the causative agent or mm, precipitating agents. The precipitation means some predisposition to this bronchial obstruction, to this bronchospasm, like maybe uh, excess of physical effort, or maybe mental stress, or maybe intake of some foods, maybe spicy foods, or sometimes there is a change of the temperature, I mean, of the air, inhaled air, and so on. These conditions, these symptoms may get worsened by the conditions of increased dryness of air also. The increased airway reactivity um, results in development of exacerbations on the exposure of these precipitating agents. And the most important thing to distinguish different conditions characterized by bronchial obstruction and to prove that this is exactly specifically bronchial asthma, not COPD, chronic obstructive pulmonary disease, not tuberculosis, not let it be canceromatosis or just tumors, other tumors, not anything else, is reversibility of airway obstruction. It's one of most typical, if non-specific, features of bronchial asthma comparing with other obstructive conditions, other obstructive diseases. So, in order to prove or exclude the diagnosis of bronchial asthma, we detect tachypnoea, increased frequency of breathing, with prolonged expiration phase. We perceive wheezing, dry rales, then prescribe the general sputum analysis or clinical sputum analysis, in the result of which in sputum we observe increased count of eosinophiles, sometimes even spirals. These spirals are such um, ex expectoration of uh, accumulated dense or viscous mucus from bronchi. That's why they have such a spiral form. Then the crystals, charcolated crystals, they are the further condensing of this mucus, and these crystals are enriched with cellular components as well, not only proteins, but also cellular inclusions. Then we perform complete blood count and biochemical tests of blood and reveal leukocytosis, eosinophilia. Sometimes there could be even increase of active phase parameters, increase of ESR, erythrocyte sedimentation rate, etc. And an essential investigation is spirometry. Spiros means breathing, metros measuring. We perform the evaluation of the breathing uh, volumes and speeds by appropriate special investigation. Um, we ask patient to inspire deeply, then expire deeply, and detect by these equipments the volumes. Then ask patient to inspire and exhale air with maximum effort. By this, we evaluate velocity parameters as well. FEV1, for example, one of most important for us, it's forced expiratory volume for first second during first second. So FVC is forced vital capacity on this slide. It's when we ask patient to inspire deeply, then expire deeply with force, maximum force. FEV1 is forced expiratory volume for first second during first second of expiration. And its rate here, it's also named TIFNO index, shows us the probability of bronchial obstruction, the relative intensity of it. We just mathematically, arithmetically calculate it. And we also might detect if we repeat these tests or just physical evaluation of the condition of patient, we usually detect the daily variability of these absolute parameters or subjective symptoms. This is because of reversibility of obstruction. On this slide, the typical X-ray of chest in sagittal projection is represented. It's typical for patients with bronchial asthma. It could be so or much better. On this slide, you might observe increased transparency of lung fields due to emphysema of lung for one hand. For other, there are signs of slight bronchofibrosis as well, right? It's not even fibrosis, it's like increase of intensity of lung pattern. It's because of continuous chronic inflammation in the bronchi. So the contributing factors to asthma exacerbation are poorly controlled airway inflammation. By control of inflammation, we understand the efficacy of treatment prescribed to this patient. It could be due to improper prescription, improper maybe preparations, I mean pharmaceuticals, improper dosage, improper regimen of use, and not enough high compliance of patient to treatment, to medical doctor, and we should distinguish these causes, right? Then, influence of cold air. Maybe you have already met such cases when some person with exacerbated bronchial asthma or even just in remission, when he or she undergoes sudden and deep inspiration of big amount of cold air, this may either provoke exacerbation or at least this attack of bronchial obstruction, reversible again. Sometimes attack of bronchial asthma may develop on the background of physical exercises, just physical training. If partly it develops because of increased speed of breathing and depth of breathing and so on, partly because of stress, yeah, mental and physical stress in this exact time. Then there could be also development of bronchial asthma itself and its exacerbation on the background of intensification and progression of infection in upper respiratory tract. Predisposed to development of inflammatory changes may also predisposition may also take place in those cases when there are other chronic inflammatory diseases in this person, like sinusitis, or rhinitis, or gastroesophageal reflux disease, reflux disease. They could be also one of possible precipitating factors might be chronic inflammatory changes in oral cavity as well, stomatological pathology. Then, of course, such a bad habit as smoking predisposes to development of bronchial asthma and its exacerbation. Environmental allergens like pollen, or they could be also professional occupational agents like different types of dust. Maybe there could be 5 groups of dust, right? They could be what uh, silica containing or biological of biological origin. I mean organic dust, or there could be some dust containing uh, how is named just 1 moment, allergens, light allergens. It could be due to influence of dust containing chromium, cadmium, manganese, and etc. And so on, different types of dusts. Or sometimes even vapors of aromatic hydrocarbons and so on. They also may predispose to sensibilization and then realization of it in form of allergic response, including bronchial asthma. The pathologic targets in bronchial asthma are smooth muscles, using beta-2 agonists, phosphodiesterase inhibitors. Then airway inflammatory cells, and we use glucocorticoids and anti-immunoglobulin E preparations and so on. Then the mechanism of pro-inflammatory uh, effects of cytokines, and we use medications based on anti-immunoglobulin, pardon, not immunoglobulin, but interleukin 5 and interleukin 4 receptors and glucocorticoids and corticosteroids and so on. Then they could be also influence on bronchial epithelium by corticosteroids and with decrease of intensity of inflammation and bronchial blood vessels as well. We may formally distinguish medical uh, preparations aiming on relief and control of bronchial asthma. So, in order to make relief, we use short-acting bronchodilators, for example, B2 agonists, ipratropium bromidum, and others. And in order to control the condition, proper condition, we use inhaled corticosteroids, Licatriene modifiers, long-acting beta agonists, theophylline, and a set of other newer agents are studied and already in process of implementation into practice. Beta-2 agonists seem to be one of most effective bronchodilators for immediate relief in case of bronchial asthma. They bind to B12 receptors on aerial smooth muscle cells, and by this they are used as a rescue for acute symptoms relief. And of course, we should realize that these conditions might have a set of side effects due to so-called overlap of B2 activity with cardiac receptors and activation of non-airway B1 receptors in skeletal muscles, in metabolism, and so on. And these medications do not cause enough effect on inflammatory components of the mechanisms of development of bronchial asthma in this case. We also use long-acting beta agonists. They by this approach we realize uh, delayed onset of action, and the lipophilic tail allows prolonged efficacy, but for prolonged time. They still do not possess enough anti-inflammatory effect. We should take this into account and probably use anti-inflammatory drugs together with them. And these long-acting beta agonists are useful as an add-on therapy or steroid sparing. They may be also associated with increased mortality and asthma exacerbation rate when used along without corticosteroids. One other approach is to use anticholinergic drugs, such as ipratropium, bromidum, tiotropium, and so on. They have slower onset of action, reduced efficacy compared with beta-2 agonists. They are essential. They are maybe very useful in case of nocturnal asthma when attacks of bronchospasm develop at night. And they have additional bronchodilatory effect in combination with albuterol, especially in acute exacerbations. And of course, one of main components in treatment of bronchial asthma uh, is or maybe are inhaled corticosteroids, glucocorticosteroids. Um, they serve as a so-called first-line therapy for mm, almost all, with exception of very mild bronchial asthma. They reduce significantly reduce the frequency of exacerbations, improve lung function, prevent or delay airway remodeling, and in inhaled form, they use they realize the effects, positive effects, with decrease of asthma-related mortality. Finally, here is the illustration how intensively there is a decrease of mortality with the use of inhaled corticosteroids. A part of above mentioned approaches, there is one more: use of dry powder inhalers, or and especially in comparison with method dose inhalers. This approach allows to increase airway deposition, improve the delivery to small airways. Finally, we expect the increased systemic absorption. These medications are relatively easier to use, and they are better for ozone layer because they do not influence on it. The side effects of inhaled corticosteroids might be thrush and dysphonia by mouth breathing, and systemic effects might also take place rarely, with growth retardation, with adrenal suppression, with osteoporosis, with cataracts. The role of leukotrienes in asthma um, is related, or their roles, they are related with the chemo attraction of eosinophiles, smooth muscle contraction, vascular permeability increase, and enhance of mucus production. That's why influence on this component of mechanism of pathogenesis of bronchial asthma also results in better effects in combination, of course, with above mentioned approaches. That's why combination controller therapy includes inhaled steroids with long-acting beta agonism, inhaled steroids with leukotriene modifiers, and these combinations are most widely used with best result. By the international approach to definition of different types of bronchial asthma, we state it as mild intermittent when symptoms appear less than 2 times a week. The nocturnal attacks of breathlessness happen less than 2 times a month, and we detect normal FEV1, forced expiratory volume per second on spirometry. Mild persistent type of course of bronchial asthma is stated when symptoms appear from 3 to 6 times per week, from 3 to 4 awakening per month, with still normal FEV1. Then, more severe, moderate, persistent type of bronchial asthma is characterized by daily symptoms more than 5 times per week, per month, probably, pardon, of nocturnal awakening due to symptoms of bronchial asthma. And when in this condition, usually forced expiratory volume per second varies from 60 to 80%. And finally, severe persistent bronchial asthma is stated in case of continuous, persistent, constant symptoms of bronchial asthma, and with decrease of forced expiratory volume per second below 60% of normal. Here is the outlook of one of possible equipment aiming on inhalation of medications. It's nebulizer, inhaler, right? One more example of individual inhaler with the tiotropium bromidum. Uh, Again, individual dosed uh, inhaler. And the treatment, as you can see, is arranged in steps according to severeness of the condition in each certain person. You may download this presentation. You may also have this recording of the lecture and uh, get through it more thoroughly if you need, of course. It's enough for dental medics to know the general aspects of this approach. Anyway, probably you will not be the person who will um, arrange this treatment, who will prescribe it. And of course, by periodical checkups and uh, physical evaluation of the person, we conduct the supervision and follow-up of the patient throughout the period of treatment. Tell me, please, whether you have any questions about the matter, about the topic at the moment. Dear students, are you there?
Yes, doctor.
Mhm. Do you have any questions?
No, doctor, we don't have questions.
Good. I see that many students already, 8 of you are present at the moment. It's great. I'm happy to meet you, to see you now as well. And please don't forget to register for the lecture. You may check, look here on the screen, you may check the link to the registration and feedback form in the invitation you have got, and I'll repeat, I will copy paste this link for you into our chat now. I have sent it into our chat. So let's make a short break for a few minutes, up to 10 maybe, and we'll continue, we'll finish bronchial asthma and continue with COPD, chronic obstructive pulmonary disease. Again, please don't forget to get registered for the lecture and ask questions if you get any, please. Okay, 10 minutes for break. Uh, Dear Mohammed, you haven't registered for the lecture. Don't forget, please. Good, let's continue. Okay, let's focus on assessment of bronchial asthma severity in office visits. First, we calculate the nocturnal awakenings episodes over the past month. Uh, we calculate the days per week with the presence of symptoms of bronchial asthma. Um, we evaluate the need for so-called rescue bronchodilators. Uh, then detect the peak flow variability exceeding 20%. Pardon, let me. Pardon, my Google Assistant has been activated occasionally. Good. And fifth, we evaluate the activity limitations. The treatment of exacerbation includes prescription of use of high-dose beta-2 agonists, inhaled, intravenously, and so on. Then anticholinergics use and glucocorticosteroids. Double inhaled dose or add systemic therapy, depending on the condition of the person, the severity of exacerbation itself. So let's continue with our second topic for today. It's chronic obstructive pulmonary disease. This presentation has been also prepared by my colleague Dr. Mazur from Lviv National Medical University. And let's discuss main aspects of COPD, chronic obstructive pulmonary disease, in relation to etiology, pathogenesis, diagnosis, principles of treatment. Same as bronchial asthma, chronic obstructive pulmonary disease is an obstructive pathology. And together, they are most common diseases of respiratory organs. About 4 to 10% of adult people are ill with COPD, and this parameter, this value is growing, unfortunately. In Europe, about 7.5% of people have chronic obstructive pulmonary disease, and mortality of patients with the COPD is about 10%, which is high, rather high. Our days, starting from the early to thousands, um, the internationally basic organ or basic organization which conducts the um, evaluation of the uh, joint general experience in diagnosis, treatment, prophylaxis, rehabilitation, study of COPD is global initiative for chronic obstructive lung disease. The widely used abbreviation is GOLD or GOLD, yeah? GOLD. According to GOLD principles, the COPD is a disease characterized by combination of clinical signs of the chronic obstruction of bronchi with inflammation, narrowing of bronchi, and emphysema of lungs. And it is independent disease. It's not just a combination. It just includes these aspects. And COPD by itself may develop independently or be a consequence of chronic bronchitis, bronchial asthma, dust pathology, occupational dust pathology, and so on. The pathogenesis of chronic obstructive pulmonary disease also includes permanent hyperactivity of parasympathetic nervous system with the hyperproduction of acetylcholine, bronchial spasm, and hypersecretion of mucus. It also is characterized by insufficiency of adrenal receptors in bronchial walls as a result of deep morphological changes with bronchial hypersecretion, bronchial spasm, cough, etc. And pathophysiology of COPD also is characterized by bronchial hyperreactivity, characterized by immune inflammation in bronchial walls. And all these finally lead to development of emphysema of lungs and so on. So if we generalize, the pathophysiology of COPD includes hypersecretion of mucus, dysfunction of ciliary epithelium, decrease of air flow in bronchi, hyperpneumatization of lungs, disturbances of gases exchange, and pulmonary hypertension. And finally, all these may result in accompanying cor pulmonale with further possible heart failure developments. Here is the illustration of the model of bronchiole. In case of COPD, you may see narrowing of its hyperproduction of mucus with increased viscosity, thickening of the bronchial walls, and so on. And here are the illustrations of bronchitic components, emphysematous, enlargements of lungs. Here is the scheme of what happens in case of emphysema of lungs. It's a remodeling of proper structure of parenchyma, pulmonary parenchyma, right, with rupture of some walls and enlargements of alveoli. The different aspects of pathogenesis and treatment in COPD also includes the role of matrix metalloproteinases, cytokines, including interferon, interleukin 13, 10, 33, and others, inhibition of angiogenesis in the pathogenesis of COPD, and as for treatment, use of inhaled steroids, long-acting and highly potent anticholinergics, phosphodiesterase inhibitors, retinoids, lung volume reduction, and other approaches. For example, macrophage metalloproteinase play a significant role in emphysema pathogenesis. Here is the illustration with immunohistochemical staining for macrophage metalloelastase in mice exposed to cigarette smoke for 3 months. You may see the expression is limited to macrophages. A significant role is played by remodeling of the structure as well, of the stroma of lungs as well. including collagen and collagenase, role in emphysema of lungs development. The small airways inflammation directly correlates with chronic obstructive pulmonary disease severity. Due to influence of precipitating and causative agents, in the development of COPD, a significant role, maybe roles even, are played by macrophages with production of metaproteinases, with antigen presentation for other immune cells, with the stimulation of fibroblasts proliferation, with involvement of neutrophils, and in turn production of elastase, metalloproteinases, and so on. And then influence on epithelial cells of lungs. And finally, we have 5 components of bronchial obstruction, which we have already mentioned at the beginning of this lecture. Not everyone was present. I will repeat. It's hyperproduction of mucus, increased viscosity of this mucus, uh, edematous condition of mucous membrane, bronchospasm, and deformation of bronchioles in this case. These 5 components cause irreversibility of bronchial obstruction, or at least decreased reversibility. Usually in the anamnesis from such patients, we reveal a history of severe smoking or right, the combination or long-standing factors like occupational diseases such as sensitization to occupational um, allergens and development of bronchial asthma or of COPD it's by themselves, or a history of occupational lung disease named pneumoconiosis, including silicosis, berylliosis, and others, and then transformation into COPD and so on. We also detect the compromised family anamnesis, development of bronchial obstruction in relatives. The complaints from patient with COPD typically is characterized by the following symptoms: chronic cough as the most early sign of COPD. Usually it develops before the breathlessness, much earlier than dyspnea appears. Then sputum production, primarily in general in small amounts, and usually expectoration of this small amount of sputum during and after the cough. Then dyspnea development. This dyspnea, breathlessness, has expiratory tinge, expiratory character. It's usually persistent. It progresses from month to month, from year to year, and usually it's worsening on physical activity, and in severe cases, maybe develop even at rest. The physical signs of COPD may also include cyanosis. Usually the cyanosis, if there is no background heart failure, it's the skin remains of normal temperature, it's warm, right? While in case if there is cyanosis caused by heart failure, when we touch the especially distal parts, they are cold because of this circulation. In this case, the cyanosis is caused by decreased oxygenation of blood. Then, involvement of additional breathing muscles in the act of respiration. They could be also superficial breathing, decrease of deepness of breathing, prolonged phase of expiration. On percussion, you may detect decrease of heart dullness because of emphysematous condition of lungs. They just enlarge, lungs are enlarged and cover the uh, heart with more thick layer of parenchyma, enlarged parenchyma of lung. They could be also so-called tympanic or emphysematous sound above the lungs. On auscultation, usually we detect wheezing dry rails with the dullness of heart tones. The main methods of diagnosis of COPD include investigation of uh, lung function by spirometry and spirography as well. Bronchodilation test on spirometry. The cytology evaluation of sputum. Then complete blood count and optionally biochemical blood tests. X-ray of chest, electrocardiography, and by indications, blood gases evaluation might be also useful. Let's focus on spirometry. On spirometry, again, I remind you that we evaluate the volumes of breathing and velocities of it, of blood, of air flow as well. The most important parameters from spirometry are forced vital capacity. We ask patient to inspire deeply and then expire with maximum force. It's maximum air volume, which is expired during the forced expiration after maximum inspiration. It is diminished in this case, and it might be lower than vital capacity without force. The second parameter is forced expiratory volume by on first second. Typically, it is decreased below 80%. The next parameter is ratio of FEV1 to FVC, forced white expiratory volume for per second, ratio to forced vital capacity. Normally, it should exceed 70% in patients with typical COPD. It could be not, it is always decreased. FEV1 might remain normal at the earliest stage, while FEV1 to FVC is always diminished. And additionally, we evaluate the peak flow of on expiration. And by this, we may distinguish COPD and bronchial asthma. In bronchial asthma, the peak expiratory flow is decreased more intensively, more severely, while in COPD, it is not so expressed. On X-ray of chest, or in patients with COPD, we detect enlargement of lungs, the flattening of diaphragm because of this enlargement and because of decrease of excursion. See, then narrowing of heart shadow as well, and it's because of overload of hearts and increase of uh, resistance of pulmonary vessels, pulmonary arterial hypertension, and compensatory hypertrophy of right parts of heart. And sometimes they could be also emphysematous bull as detected by X-ray mostly. Here is the typical X-ray of patient with COPD. We may observe hardening of lung pattern and emphysematous condition of chest, increased transparency of lung fields, and deformation of hyperinflation, right, of chest. One more example. In this case, we observe even more intensive hardening of lung pattern and hyperinflation condition of chest. The bronchodilation test is performed during the spirometric investigation. After basic one and advanced, we ask patient to inhale the standard dose of bronchodilator and repeat the investigation in a in some time, depending on the exact methodics in different hospitals. It could be from 15 minutes to 45 or 60 minutes. The standard is inhalation of 400 micrograms of salbutamol or 80 micrograms of ipratropium bromidine. And if forced expiratory volume per first second increases for 15 and more percent, we state that reversibility of bronchial obstruction is high enough, and this is not typical for COPD. It's typical for bronchial asthma. If this improvement, increase of FEV1 is less than 15%, probably this is COPD or some other condition, bronchial obstructive condition with low reversibility. On this slide, spirometric COPD is represented with 4 stages and 4 appropriate 4 severity levels represented, and for example, on first stage and mild severity, the FEV1 is below 80%, the ratio of FEV1 to FVC is less than 70%, and as a rule, chronic cough with sputum is present, dyspnea also. On second stage and moderate severity, increase is between 50 and 80%. FEV1 to FVC ratio remains less than 70%, and symptoms are more expressed with presence of dyspnea during physical activity and exacerbation, in addition to chronic cough, of course. On third stage, with severe course, the FEV1 is between 30 and 50%. FEV1 to FVC ratio remains less than 70%, and symptoms cause perceived significant worsening, decrease of life quality or health-related quality of life, the full name of this parameter. The fourth stage with very severe course is characterized by decrease of FEV1 below 30%, and if FV to FVC ratio may remain less than 70% or be even more, it doesn't matter in this case because FEV1 is that sometimes just arithmetically, if we want to FVC ratio might be increased while it's severe pathology. And rather often in this condition, a chronic respiratory failure develops, and a set of other complications and accompanying conditions develop. The principles of treatment of COPD include such as increase of intensity of treatment in correlation with COPD severity, the permanent basis therapy, and evaluation of individual sensitivity of patient to different medications with permanent control of efficacy of treatment. And the fourth principle is use of inhaled medicines. Here is the example of peak flow meter by which we evaluate the parameters of this parameter in patients. One more example of inhaler. We also have discussed it in relation to bronchial asthma before. Individual inhaler with tiotropium bromidine in this case. And the treatment itself. It includes inhaled cholinelytics of short-action ipratropium bromidine, Berodual H, and others, which has more slowly beginning but longer action than beta-2 agonists, and prolonged action with tiotropium bromidine or Spiriva inactive and is active for 24 hours. Inhaled broncholytics include beta agonists of short-action salbutamol, phenytoin, and so on. They have fast beginning of action, but duration of 4 to 6 hours. And beta-2 agonists of prolonged action with salmeterol, formoterol, and so on, which are active for about 12 hours. And methylxanthines, such as theophylline of prolonged action, might be useful, Theopec, Theotard, and so on. And glucocorticosteroids are used as well, especially for permanent basis therapy in patients with COPD of third to fourth or advanced stages. Mostly in inhaled form they are used. And prednisone might be used only during exacerbation and is not recommended for basis therapy. Inhaled glucocorticosteroids, beclomethasone, budesonide, fluticasone are used, or Seretide, it's glucocorticosteroids in combination with salmeterol, is widely used in patients with third to fourth stages of COPD and often exacerbations in anamnesis. And as you can see, the management of COPD is based on evaluation of uh, stages and severity. If there is 0 stage, just at risk, or second stage with mild COPD, or third with moderate COPD, or third with severe COPD, or fourth with very severe COPD, we have general common approaches. It's avoidance of risk factors, smoking cessation, reduction of indoor pollution, reduction of occupational exposure, and influenza vaccination, and for instance, COVID vaccination as well. While in in different stages, we have some options or peculiarities. In stage 0 at risk condition, maybe chronic symptoms are present with cough and sputum expectoration with no spirometric abnormalities. In this case, the main recommended treatment is smoking cessation. On first stage with mild COPD with appropriate parameters as we discussed with you before, a short-acting bronchodilators are useful. In second stage or moderate COPD, short-acting bronchodilators used and regular treatment with one or more long-acting bronchodilators together with general rehabilitation. On third stage with severe COPD, the recommended treatment includes short-acting bronchodilators, regular treatment with one or more long-acting bronchodilators, and inhaled corticosteroids in case of repeated exacerbations, and of course, respiratory rehabilitation. On fourth stage, most advanced with very severe COPD, short-acting bronchodilators are needed. Regular treatment with one or more long-acting bronchodilator. Inhaled corticosteroids with repeated exacerbations. Treat complications like heart failure and so on. Pulmonary rehabilitation, long-term oxygen therapy in case of respiratory failure, and consider surgical approach to treatment if needed. Here is the illustration of this staged therapy or therapy depending on the severity. Thank you. And if you have any questions, feel free to ask. You have about 1 minute for these, please. Dear students,
Yes, doctor.
are you there? Mhm. Okay, it was nice to see you, to meet you. Thank you for registration. I see 8 of you here. Now making the screenshot of our chat, and I'm happy to meet you. See you one of or some of next lectures. Okay.
Okay.
Okay. Thank you. Good luck. Keep healthy.
Thank you, doctor.
Thank you.
Thank you, sir.
Lectures are recorded, so I'll upload these lectures to the YouTube channel and make it available for you. Anyway, all presentations, links to them are included in the invitation. So you may just follow the link. Here it is.
Yes.
Good luck. Bye.
Have a good day.
And to you, thanks.
Goodbye.
Goodbye.
Bye,
Thank you,
doctor.
doctor.
Thank you.